So, thank you so much for the nice introduction, and thank you QPRN for the support, and also providing the opportunity for the researchers to discuss their research, and also provide some information for people who may use that. So what I'm going to talk about is the systematic review and meta-analysis that we have recently done. The study is under review at this moment, and hopefully we can publish it soon. I present a study in the Canadian Pain Society. So we are going to talk about if tailored psychological therapy can improve the effect of intervention, or if stratification people with low back pain based on their psychological factors can improve the treatment result in this population. So as it is obvious for clinicians and researchers, the global pandemic of low back pain is increasing. Based on the epidemiological study, it was 377 million people in 1990, and with the year of 2020, it increased to 6 million, 19 million, and it is predicted that since 2050, this number can increase to a huge number of populations suffering from low back pain, like 840 million, which is a shocking figure. So in Canada, the cost of medical expenditure alone for low back pain are estimated between 6 and 12 billion annually. And it increased a heavy burden on the society and the financial situation and healthcare system. Low back pain is multifactorial, and it is not limited to physical aspects, but also the psychological factors significantly affect on developing of chronic low back pain, or developing of chronic pain in general, and also chronic low back pain in a specific. Psychological factors like depression and anxiety, stress, catastrophic thinking, avoidance behavior, they have been seen as a prognostic factors, as a predictor of pain development, and also sometimes in some study as a cause of pain development or chronic pain, specifically some factors like depression and anxiety and stress. And there are many study working on these factors and their prognostic power and ability to predict pain chronification, and also as a causation factor of the pain and pain chronification. This circle can show how psychological factors can affect on chronic pain. So patients with chronic pain, they have decreased activity, and it leads to catastrophic thinking and negative emotion. And then these types of emotion can lead to avoidance to participate any physical activity or any treatment. It leads to distress, and again, that's a circle that can lead to a development of chronic pain. Because of that, in recent years, or in last decade, the psychological intervention have been focus of many researchers for the treatment of chronic pain in general, and chronic low back pain in specific. Psychological intervention like cognitive behavioral therapy, ACT, mindfulness, behavioral therapy, and recently pain science education, or any psychological treatment in addition to physical intervention like physiotherapy informed treatment, which is including of psychological intervention and physiotherapy or physical intervention. are interested to focus by many researchers and clinicians, and there are many studies focusing on the effect of psychological intervention on the improvement of the low back pain and chronic low back pain. This psychological intervention can improve. The main goal and aspects of this intervention are to reconceptualize the unhelpful belief and some wrong thoughts about the pain and about the chronic pain. So they can change our thoughts about and our outlook about the pain, change the feeling, and finally change the behavior. Changing the behavior means encouraging us to participate in physical activity, avoiding from having sedentary life, and try to improve our daily routine. This is the main goal of the psychological intervention. Previous systematic review with meta-analysis study, which include like 90 studies focusing on psychological intervention for chronic non-specific low back pain, has shown that although psychological intervention have a small and short-term effect on pain and disability, the long-term effectiveness is uncertain. So before I talked about this result, I just want to focus on the term of chronic non-specific low back pain. Maybe this is a question for some people. So in terms of time, we define the pain as acute, subacute, and chronic. So acute is the pain acute low back pain is the pain less than 3 months or less than 50% of the day in the last 6 months. And chronic low back pain is the pain more than 3 months and more than 50% of the day in the last 6 months. And non-specific low back pain is a back pain that we cannot find a specific reason for the pain. We cannot have a specific physical reason for the pain. And most of the time, it's related to the psychological reason. So we call that as a non-specific low back pain. However, the non-specific low back pain is a wide area, is a wide term, and the definition is not yet clear. So this study focusing on this population showed that the psychological intervention in general can have a small and short-term effect on pain and disability, and the long-term effectiveness is uncertain. So this conclusion can be because using one-size-fits-all approach instead of tailoring intervention, like providing one intervention for many people without considering the fact of tailoring intervention based on each individual characteristics, and also lack of consideration of patient selection based on their psychological factors. So there is no selection there is no way to select patients based on their psychological specific factors and provide the intervention based on those factors with the hope of having long-term effectiveness of the intervention. So one strategy is to stratify or classify patients based on their psychological factors. So if you consider 3 types of population, in the green is population with low psychological factors. With in the yellow one is the medium psychological factors, and in the green one, the patients with high psychological factors. But what is the meaning of medium, low, or high? They can be achieved by a cut of the questionnaire or some classification-based questionnaire like a STARBAC that help us to classify, with asking some question about psychological factors, help us to classify the patients on the low, medium, and high level of disability. And cut off of the psychological questionnaire like depression or Tempo scale for kinesiophobia. So based on them, we can classify patients in the low risk of fear avoidance belief or kinesiophobia, or high risk of kinesiophobia. So patients with the high risk of psychological factors are those who need psychological treatment. And the benefit of this type of stratification and classification is to prescribe a specific treatment to a specific subgroup of individuals with smaller characteristics and providing tailored treatment targeting patient psychological factors. There are some studies use a stratification for patients and provide some psychological intervention. The effect of these types of strategies is still unknown. So we define to do a systematic review to collect the studies based on the specific criteria that I will mention, to see if these stratification methods can improve the effects of psychological intervention on patients with low back pain. So the aim of the study was to determine whether using tailored intervention addressing psychological factors is more effective in improving pain and disability than intervention without psychological components. So for doing a systematic review, we have some criteria. The first is searching a strategy based on the specific keywords. We search on different predefined database that I've provided here, like IMBAS, Cochrane's, and Midline, Web of Science, and also. So we try to find a randomized controlled trial until November 2023 to select the study based on the predefined keywords. And the participants including in those studies had to be above 80 years of age, having non-specific low back pain. It can be acute, subacute, or chronic. And more important, having psychological contribution to their pain. So we try to find a study that the authors or researchers use questionnaires like a STARBAC or the other psychological questionnaire and divided the patients into high risk of psychological factors based on their specific definition. Like, for example, the score above 30 in Tempi scale for kinesiophobia, for example. The intervention in the included study should be any intervention that targeting psychological factors. So it can be CBT, it can be ACT, it can be education, even yoga that has a psychological component inside, or the study that combines psychological approach plus non-psychological intervention. As I previously said, like physiotherapy informed strategy by adding psychological intervention to the physiotherapy. And also the control group can be any alternative treatment that did not include psychological components. The outcome, because we have a wide topic and there was a possibility to include many studies, so we only limited to pain intensity and disability for the outcome, and we defined the term for short term, mid term, and long term. For the short term is the post-intervention till 3 months after the post-intervention, and 3 months to 6 months is the mid-term, and above 6 months as a long, we consider it as a long-term effect. So for the primary analysis, I didn't mention the picture of the meta-analysis because maybe it make it a little bit more complicated. I wanted to be more simple. So for the primary analysis, we include 29 studies, and in general, for the primary analysis, we include all the study and try to find if this stratification it can improve the effect of psychological intervention. We didn't divide the psychological intervention, but add all of them. So the result was that for the short term and mid term, psychological intervention, a stratification could improve the effect of psychological intervention. But in the long term, we couldn't see significant changes. However, the small of the differences in short term and mid term, considering it was significance, the effect was small. compared to usual care. I mean, clinically small. Statistically, it was significant, but clinically, it was small. For disability, we have seen the short-term, mid-term, and long-term effect of improving psychological intervention compared to usual care by classification patients based on their psychological factors. Again, it was statistically significant, but clinically, it was a small differences. For the secondary analysis, we divided the stratification methods. We had different types of classification, like based on the fear avoidance, based on the risk classification, based on the depression, and based on the different types of psychological factors. So we try to see which of these classification can better improve the psychological factor, the psychological intervention effect. So for pain intensity and disability, both at short term, the depressive symptoms was the best types of classification that could improve the effects of psychological intervention. So it means classifying patients based on their depressive symptoms can significantly improve the effect of psychological intervention for pain and disability, both at short term, but not mid-term or long term. And the considering of treatment strategy like CBT, like combination of psychological intervention with physiotherapy, like pain education, like behavioral therapy. Focusing on treatment strategy, we could see that combining physical activity and psychological factors are the best treatment for improving low back pain compared to the usual care for pain intensity and disability. But we could see the long-term effect for disability, but not for the pain intensity. Finally, as we can see the result, although psychological intervention show some marginal benefit over usual care in reducing pain intensity, the clinical relevance of such improvement remain questionable. As I mentioned, the effects were significant, were statistically significant, but they were not clinically meaningful. And the minor differences observed are not sustained over time. So most of the effects were in short term and mid term, but I couldn't see the long term effect specifically for pain intensity. It can increase doubt on the long term efficacy of these types of treatment. So in terms of disability, psychological intervention might offer a slight improvement compared to usual care at various follow-up intervals. However, the significance of this improvement is debatable. Despite the modest differences, we cannot neglect the benefits of psychological intervention, specifically considering the psychological safety and feasibility. I want to discuss this part a little bit more. So when we look at the clinical effectiveness, we can see that the clinical effectiveness was not big. But despite these modest differences, we cannot neglect the benefits of psychological intervention because they are safe and they are tolerable. And based on the previous study, they are feasible to apply, and there is low additional cost associated with adding psychological intervention to the physiotherapy. Also, based on the previous study, 86% and 94% of participants report that psychological intervention are logical, and they were overall acceptable by the patients, and patients were satisfied with receiving psychological intervention. On the other hand, the psychological intervention can decrease the cost of the treatment. When this is added to the physical treatment, there is less need to visit the psychotherapist. And if the healthcare professional and physio can be trained by the psychological experts, then they can provide psychological intervention for patients along with physiotherapy intervention or the other non-psychological factors. Moreover, the stratification of patients based on their psychological factors can provide some information regarding emotional, cognitive, behavioral, and psychological factors of the patients for healthcare practitioner and provide us some information that help them to design the specific intervention for the patients. Finally, as a limitation of the study, so when we have done the meta-analysis, we need to, and systematic review, we need to check the risk of bias and the quality of the study for adding to the meta-analysis, and also grade the meta-analysis based on the low, medium, and high certainty of evidence. So for this study, we could see the most included study has the high risk of bias, and also the meta-analysis had low certainty of existing evidence, which underscored the imperative for further high quality research. Thank you so much.